Hi. Hello, welcome to Knock Knock Hi with the Glaucomfleckens. I am Will Flannery, also known as Dr. Glaucomflecken.
I am Kristen Flannery, also known as Lady Glaucomflecken.
And what a show do we have for you today. We're talking with Dr. Mark Lewis, someone that we know quite well, and we'll talk about that in a second. But first, we got some mail yesterday.
Mm-hmm.
We've been getting some mail because we are preparing for a very long
flight.
The biggest trip that we've ever taken as a family. We are going...
as a person, I think, for me.
That's me too. Yeah, we're going to Australia.
Yes.
We are spending some time in Sydney and Adelaide, and I'm speaking at a conference there, but we're turning it into a family vacation. So we get this big box in the mail, and I open it, or Kristen opens it. I look in, and I'm kind of confused, and I ask her, "What is this?" And she says, "Oh, those are my neck pillows, like multiple." Mm-hmm. And so what you had decided to do was, in order to try to sleep on this 17, 18-hour flight we have to take.
Yeah, got to make sure I have a good neck pillow.
You want to do experience with the different types of neck pillows.
Correct. Okay, so for context, I have to back up. First of all, for myself and for our younger daughter, if we are awake for too long, like, we're talking, this is another reason I could never have become a doctor, because if it's at like hour,
18, 19, 20.
Right. If it's coming on 24 hours of awakeness, we will just throw up.
They
just
will,
uncontrollably.
I've seen it happen.
Mm-hmm.
I would not say uncontrollably.
No,
but
I just mean like we can't control how this, like it's
it'll
just
happen.
going to happen.
So anyway, yes. So they have this weird, like,
I don't know if you know what that is out there. Somebody listening or
sleep
watching,
deprivation
please do tell me,
vomit,
because I would like to fix it.
So
anyway,
in order to combat
we have this, so it's very important.
Yes,
that we get some sleep on the plane. Otherwise, we will both be vomiting over the Pacific Ocean in a tube that we can't escape from. So,
all right, we understand the implications of this. So, what have you done to try to prevent this?
Okay, so that's background number one. Background number two is that I have, some joint issues due to my hypermobility. And so, I've had a neck surgery. I've had to have a cervical disc replacement. I have a lot of just chronic pain up and down my spine, right? And my neck is a common offender. So I also need, not only do I need something that's comfortable enough to sleep, I need something that's not going to debilitate me.
So you need something ergonomic.
I need something that's very supportive in a specific way.
So just to fast forward here, the things that she ordered are hilarious.
Yeah, so I got, 6 or 8. I Googled to see like what are the best ones, and I couldn't decide just from reading on the internet, so I had to try them. So I just got all of them, and I figured I can try them all out and then just return the ones I don't want to keep.
So one of them is just your typical like neck pillow, but another one is this large, what shape is it? I don't even know.
Oval?
Oval shaped thing that goes over her head, and then she leans on. It's like designed to like lay
for like tray table sleeping.
On the tray table. Yeah. But what you look like is...
It's called the ostrich.
Okay, it's called the ostrich, but you look like one of the zombies from The Last of Us. If you've seen that show, The Clickers, like that's what she looks like. Or even like from Pan's Labyrinth, that's a good one. Where the guy with the eyeballs on his hands.
Mm-hmm. That guy freaked me out.
Yeah, that's what you look like with the ostrich on your head.
Yeah, because it like goes over your head as an oval, and then up at the top on either side of your head, it's got holes because it's meant like, remember, you're leaning over a tray table, so your forehead's on the tray table, and then your hand is in these holes right above both of your hands are in the holes above your head so that you have somewhere to put your arms.
I support whatever it is you need to do to avoid vomiting on our trip. So however much money you feel like you need to spend investigating these options.
You got to be able to, sometimes you just have to try it out. So, yeah.
Right. Well,
going to do it. Well, I'll report back.
Perfect. Yeah, I'm sure everyone's going to be just waiting on pins and needles for that. All right, let's get to our guests. We have Dr. Mark Lewis, who is a medical oncologist, who is the director of Gastrointestinal Oncology at Intermountain Health and chair of digital engagement for national cancer research groups. And we actually just interacted with, we met Mark in person for the first time a couple weeks ago.
Yes. Yeah. We've known him from Twitter for a few years, but he was in town for a conference. And so we met up for dinner, and we had a lovely dinner and good conversation. We went out for ice cream afterward. We brought our kids with us, and it was just this really, really good time. And I think that it speaks to the character of Dr. Lewis, that when we left on our way home, and this is well past the kids' bedtime at this point, right? Well, on our way home, normally our 8-year-old would be complaining about something or another because she's 8. That's what they do. But what she did after the lovely evening that we had is she just sighed really contentedly from the back seat and went, "I love you guys." And that was just... to me, that is the epitome of what an experience with Mark Lewis is like. So we go into in the episode a little more about how we know each other, but that is the kind of person that he is and the kind of physician that he is. So really, really good episode today.
Maybe also had a little bit something to do with ice cream.
Could have.
I'm just saying, I'm just throwing that out there, But yeah, certainly the medical oncologist guest helped our 8-year-old enjoy the evening, but had a great time. So let's get to it. All right, here is Dr. Mark Lewis. Mark Lewis, Dr. Lewis, thank you so much. I feel it's so formal calling you Dr. Lewis. I can't do it, so I'm just going to call you Mark.
Right.
Because we've interacted a handful of times, and our families know each other.
Yes.
And so our first question I have for you, are you a white coat guy? There's different schools of thought here, because like there's some doctors be like, as soon as they're done with training or med school, you're like, ditch the white coat, never again. Mm-hmm. Some people are very attached to their white coat. There's no wrong answer. I'm just curious what your philosophy is.
I'll tell you my philosophy, Will, and thank you, by the way, it's lovely to see you guys, and this is just a treat to be here. It helps me project, I mean this quite seriously, actually, it helps me project some sense of gravitas, because as we'll talk about, like what I do for a living is serious in its implications, and I know I still look young and, maybe give off the impression that I haven't done this long enough. And so I know it sounds almost like a prop, but to set the stage without coming across as intimidating, I do want to come across as semi-competent.
Sure.
And I'm talking to you guys in a clinic day. And this is absolutely delightful sort of break from some of the things I've been addressing. But that's why I wear the white coat. And the other thing that's helped, if I'm honest, Will, is as I've gotten older, I'm getting visibly grayer. And literally, it's been years since a patient asked me how old I am. And I take that actually with a tiny bit of sort of satisfaction. One of my colleagues and I, we call it gravitas, meaning that the gray hair gives you just a tiny bit of seniority, and then people are more likely to listen to you. But in all seriousness, it all comes back to establishing trust with the patient, making sure they feel comfortable with me. Because if you don't have that rapport, and I'm going to be giving you chemo, and I know we're jumping right into the meat of the conversation, it's going to be a very difficult sort of therapeutic alliance. So that's the real reason.
It's been a while since anyone asked you about how old you used to get those comments.
Well, I did. I did. I got those comments a lot. And then I had a cardiac arrest. And then I developed a lot of gray hair after that. And all of a sudden I wasn't being asked. I was more being asked, "Are you okay? Are you?" Yeah.
I was literally at a restaurant this weekend, and they had a sign on the wall, and it said, "If you're under 30, prepare to be carded." And I was sitting there kind of waiting to see if they would ask. Nothing. So they're like, "All right, old man, come on through." So we're past that.
Well, I'm glad you could join us on clinic day. You certainly look like you've just been in clinic with your wearing a stethoscope and your white coat. And so... Yes, as we've alluded to already, you are an oncologist, and you are the director of gastrointestinal oncology.
That's right.
And also, you have this other title, the chair of digital engagement for national cancer research groups.
Yeah, what is that?
I'm not sure what that is. Because it sounds fancy.
Well, yes. So let me disabuse you of that notion, Will. So I'll say, how Google has this autocomplete feature, right? So allegedly we're in the era of search engine optimization, but if you go to Google and you start typing in a phrase, it'll finish your search string, right? So a couple years ago, I was really curious, how does the general public perceive what I do? And so I put in the phrase oncologists are, and frankly, I was enlightened but horrified by the results. It said literally, and I can send you, I have a screenshot of this. It says oncologists are murderers.
Oh.
Right. Yeah. So we have a little bit of a PR problem right off the bat.
Sure.
That's right.
Oncologists are poisoners, and I can kind of see where they came in there.
I mean, in a literal sense, sure.
Yeah. And thank you. Yeah, that's fair. And then, I think oncologists are criminals. It went on.
Oh my gosh.
Wow.
And I thought, gosh, we have a lot of work to do to rehabilitate our image. And so, well, to answer your question, semi-seriously, what digital engagement means is reestablishing at least a fraction of the public trust. And there's actually really good research, and you and I have actually both had cancer. There's really good research that when someone's first diagnosed, and if they have the luxury of internet access, 97% of people, and this is no surprise, will look up their diagnosis on the internet, and 94% of them will use Google. And so to me, it's actually very relevant what search results are going to be yielded if you're doing these sort of broad-based investigations. So what we are looking to do with digital engagement is humanize oncologists. And I'll come back to thanking you for your role in all this, but also specifically making people aware that clinical trials are not about making people guinea pigs. That's one term I really want to try to jettison. It's more about, we know that what we're doing right now is not good enough. How do we make it better? And short of sheer blind luck, the only way we make it better is by asking really thoughtful research questions. And the final piece of the puzzle is, we respect ethics, we respect autonomy. If you're going to enroll in a trial, back to actually what we were saying at the beginning, you better trust the clinicians and the scientists who are taking care of you. This is a huge sort of self-sacrifice that you're making. Again, usually you're hoping to get something back, but you better think of oncologists as something a lot more than just as murderers, So it's a very long answer to your question, but one of the reasons I'm the chair of digital engagement, and specifically why my Twitter activity sometimes comes across as looking a little silly or frivolous, is I am trying to soften sort of our public persona and make us feel, and I hope this is authentic, come across as more authentic and approachable.
Well, you're talking to the king of frivolous content, so don't even.
Although I'm sorry to tell you this, but usually Mark's Twitter feed makes me laugh more than yours does.
I don't, because you've heard all my jokes 1,000 times.
It's been many years
that makes
now.
Sense.
I'll let you talk to my wife, and you get completely the same answer. So yes.
Yeah.
Well, so it's surprising to me hearing about this PR problem that oncologists have, because from my perspective as a physician, like it's like oncologists have some of the hardest jobs in medicine because it's such a growing field so quickly. You have all these new therapeutics like all the time that are coming out. It just seems like a very challenging field. You have to have a lot of empathy. And so it's surprising to me that maybe the general public has a negative image of an oncologist.
I mean, that's really very kind of you to say, Will. And I think the difference is, one, you're inside healthcare. Yeah. Two is you, and I guess not really that indirectly, Kristen, have benefited hopefully from an oncologist taking care of you. Obviously, she was the one that had to bring your heart back. There wasn't an oncologist present when you rested at home. But I think it does take some sort of personal brush with the disease, whether it's you or your family member, actually to kind of see what it is that we do. And one of the things we can discuss is oncology is actually a lot more than chemo. Thankfully, it's becoming a lot more than chemo. But for many years, it's fair to say that, if you were to describe my work in maybe 2 words, you could say, chemo doctor. And I think what actually happened with our negative image is I think we, the people, the doctors, got conflated with the nasty, nasty toxicity of our drugs. And full disclosure, like I know chemo is horrible. No one ever wants chemo. I don't want to give chemo. In fact, part of my job is to convince people when they need chemotherapy, and then when they do need it, to try to make it as tolerable as possible. So I think you're very kind to say that. I think that's where some of this reputational trouble came from. And then, as I was also alluding, if we're not extremely careful in how we describe clinical trials, we will come across as mad scientists who are sort of, playing fast and loose with people's lives. And that's the farthest thing from what we're actually doing.
How do you come up? How do you have that conversation? That's interesting to me, just because I understand it seems like it'd be very easy to
mess
portray
it up.
that as experimental, right?
Yeah.
And that's a scary word for people, especially when you're talking about, cancer.
Yeah. I think the way I put it is that the only way forward is sort of rational and careful experimental design. Because again, I'm lucky enough. I've had, as we discussed, a relatively short to mid-length career at this point, and I've seen it change so much. Like literally, I had a great fellowship, a great training. I kid you not, if I practiced exactly the way I was trained now, and I've been out more than 10 years, it would be malpractice. That's how much it's changed.
Wow.
And I think what we've all signed up for on our side of the table is lifelong learning. We basically said, listen, nobody wants to be practicing oncology the way it was 20, 30 years ago, heck, even 5 years ago. We want to be better than that. However, the only way to get better is essentially crowdsourcing our knowledge. And it's tough because some patients have to go first. It's like, we can get into this too. When I was having my pancreas surgery, I was meeting my surgeon, or surgeons the week beforehand. And one of them was his first operation here at my institution. I remember thinking, this is kind of an interesting situation to be in, where I know that I am, for want of a better phrase, my surgeon's first, right? No one ever wants to really be first.
Right.
On the other hand, we know that sort of, again, pioneering is necessary because the status quo is not nearly good enough. So the way I couch it is, I talk about the standard of care. I say, listen, the standard of care, what we know now can get us this far. But, I'm honest with them that I think we are still in, if not the infancy of this field, it's adolescence. And the only way to fully mature is through trials. So if you just take a little bit of time and try to, again, dissuade them of this notion that, trials mean that you're totally guessing and it's completely improvisational, then they tend to come around. And also, if you can demonstrate the potential value for that person, that tends to be very powerful. I've actually taken care of some complete altruists, people who say, listen, Dr. Lewis, I realize that the odds of me benefiting here are slim to none. I still want to do it because I want to make it better for the people that come after me. And that's the kind of selflessness that you see all the time in this field. And it's just so touching, like who does that? And the answer is patients with cancer do that. They are among the most noble people I've ever met.
There is something about the experience of having cancer that and you two know it better than I do, as former cancer patients yourself, but it really adjusts your perspective on life and on what you want to do with your time and with your own life. So that doesn't surprise me at all. I mean, it's unfortunate, but it's not surprising.
There's an intentionality to it, Kristen, and I think you guys, or I guess I'll include myself in our group, like relatively young ages. We've had to confront mortality. And my father actually had a great quote about this. So he was a minister, he was a theologian, and he was referencing a psalm where it talks about, the average life expectancy being 70 years and 10. And he said, you know what? Our life expectancy, that's not a guarantee. That's an average. And in any bell curve distribution, some people will fall on the long part, the desirable part, and some people will be on the very abbreviated and undesirable short part. And he was actually, tragically, the latter. So he wrote, when he was in his early to mid-40s, he said, I'm having a midlife crisis with his cancer that may prove closer to its end than its middle. And he was absolutely right. And so I think from a very early age, I realized, and then it was really brought upon me when I had my cancer, boy, there are no guarantees here. And I won't even pretend to understand what you guys went through with the sort of hyperacute, shock of your cardiac arrest. Well, and Kristen, again, kudos to you for your remarkable resuscitation efforts. But, I think it just shakes you. And this is stuff people don't want to talk about. Like denial is so powerful. Like you want to believe, especially when you're young, that you have something approaching immortality. And I think the other thing that really changes your perspective is when you have a parent that gets ill. I think when we're young, it's actually comforting, almost necessary to imagine that your parents are going to live, if not forever, for a very, very long time. And it's like the scales fall from your eyes when you realize that, yes, they're human in every sense of the word, but also that they are not just fallible, but they're mortal, they're vulnerable. And I think that that's a change in perspective that you get either, again, having a serious illness yourself or witnessing a loved one go through it. And again, from a very young age, I saw my dad go through it. I saw my mom support him. And Kristen, we can certainly talk about caregivers and the vital role you play. But I think that's the difference. I think once you're confronted with your own mortality, it quickly moves from some abstraction in like a future you problem where you're going to be in a retirement home 5 decades from now to something like, wow, this is a clear and present danger to me and my family, and I have to face it.
Yeah, I spent a lot of time processing my mortality and my, at times tenuous mortality, it seems, through humor, through jokes.
I've noticed. I've noticed.
You've noticed. If you've noticed that, if you could tell. But whenever I woke up in the ICU after my cardiac arrest, I pretty much immediately started tweeting and talking about it, which I've been very proud of myself for quite a while. And then that I was able to do that. But then I learned that you actually live tweeted through your Whipple surgery, which made my accomplishments not seem quite as impressive.
Well, I feel like there's a caveat coming here.
What?
Mark, you go ahead.
Well,
break it to him gently.
Yes, well, I think the caveat might be that the other people were tweeting for me. That may be the most important caveat. But Kristen, I'm glad you're clarifying, because if I had it to do
you're
over
supposed
again,
to come on, you're supposed to let people think maybe he was able to live tweet through his own surgery. I mean, come on.
But that's what people thought. So the biggest mistake I made, and I have a wonderful social media team here, and I'm happy to tell you like how it all went behind the scenes. But basically, I gave them control of my Twitter account. And maybe like the one time in my life I've ceded control of that to someone else. And I had friends around the country who were using this to follow my surgery. So again, people that care about me, who I know, and they thought, this is true, Kristen. Some of my non-medical friends thought that they were waking me up from general anesthesia.
Oh my gosh.
Sort of like letting me like comment on what was going on, tweeting and then putting me back to sleep. And I'm like, listen, I know I have a dopamine addiction. It's not quite that bad. All right. You can put me out and someone else can do it. But no, it was a remarkable experience. And, from my wife, I mean, again, exceptional circumstances, but that's how she got updates on this surgery, which took 6.5 hours. The surgeon didn't have to come out of the operating room and be like, hey, listen, this is how your husband's doing. Surreal for her as it was, she was getting live updates just like everyone else. And, 99% of the feedback we got that day was wonderful and positive. And I woke up from surgery. I thought I was hallucinating. I was looking at my phone. There was all these like notifications from people I've never met. There's like 3 million messages or something. It was unbelievable. And the fact that, we did it that way was obviously very exhibitionist. But the reason I did it, if I can be very serious for a second. So the surgery I had is the only chance of cure for most patients with pancreas cancer. And in my clinic, if I can get my patients, it's sort of a team effort, if I can get them to the point where they are candidates for the surgery I had, that is something to be celebrated. And yet, I cannot tell you how many of them are afraid of the operation. This surgery is really complicated. The other reason I tweeted it, if I'm honest, is I wanted to see how it was done. Like, I wanted kind of a step-by-step roadmap, because what it does is it completely rearranges the anatomy of your upper gut. And so much so, the way I've described it is the surgeon does to your abdomen what Picasso did to faces, like takes the parts that you could recognize and then like rearranges them. And then when you're done, you're like, oh yeah, I can kind of see like a liver here.
Yeah.
And maybe
you have
part of a bowel
cubist
here. Yes,
GI
cubist.
tract.
I have a cubist GI tract. Thank you, Chrissy. Yes. And so I'm a big believer that things are less scary if they are illuminated. I think monsters are less frightening in the dark. And I thought, if I wake up from this, and I honestly did not do it for clout. It's the worst reason to possibly have a Whipple surgery is for clout.
Yeah.
But don't try this at home.
Much easier ways to get clout.
Don't do that.
Yeah, exactly. I thought if I can convince one person that the Whipple operation is right for them, then this was all worthwhile. And it has been. It's been a remarkable tool. I use it in clinic. I use it as an example of not, look at me and I got through it, but these are the steps that you would need to go through. And it really kind of lets the patient have open eyes as to the complexity of the surgery, its recovery. I was also very forthcoming about the fact that it was not a straight linear road to recovery. It was actually extremely bumpy. I couldn't eat for 5 weeks. I was fed through an IV. I had a tube in my nose. And again, it opened my eyes to all these outcomes of what we do as doctors that aren't that easily captured in labs and scans. The actual patient experience and the caregiver experience. My wife, Kristen, you'll appreciate this. I woke up one morning after my surgery, and it was extremely romantic. I was vomiting bile. Okay.
Ooh, yes.
Yeah. And
just what you want to wake up to in the morning.
Yeah, I know. I bet when you took your vows in sickness and in health, and when I took my vows in sickness and health, this is not exactly what you envisioned, right?
Vomiting bile was
vomiting bile.
Yeah.
But my wife's a doctor, and specifically, she's a pediatrician. And she looked at me and she said, listen, you have 2 options. She said, number 1, we can go back to the emergency room, and you know what they're going to do, or you can let me handle it here at bedside. And I knew what she meant. So what I needed at that point was I needed a tube reinserted down my nose to my stomach to drain out all that lovely bile.
Would you let me do that for you?
An NG tube.
An NG tube. That's right.
That's one of those things, along with a Foley catheter, that I'm terrified. Having put in several of those and of each of those, it's just something I never want done to me. But I understand that it's necessary. So
for both of you, you'll appreciate this. So I agree. I didn't really want it either, but I also really didn't want to go back to the hospital. And I love and trust my wife.
And you wanted to stop vomiting bile. So
this is true. Yes, that was kind of priority number 1. And so I was like, sure, honey, go right ahead. And this is the best part. So we had it in NG tube because, of course, we do. We're a 2-physician couple. And
you had it in
Yeah, just have it handy. Medicine cabinet.
All right. As one does.
Got a trach in here. Got
all
some
these things.
speculum.
All kinds of stuff.
Yeah. And so she's threading this tube, into my nose. Now remember, she's a pediatrician, right? So she's different. She's used to a slightly different caliber of nostril. So she's putting it into my nose, and she goes, "Mark, your nostrils are huge." And, at the time, I'm still vomiting the bile, but I've been trying to laugh at the same time. And it's all relative. So bottom line is,
my goodness,
my wife saved me. Tube went down. But again, these are the parts of I kind of don't like the word journey because it implies this was some sort of voluntary trip we signed up for, farthest thing from it. But these are parts of the experience that, and Will, I know you know this, and until you go through it yourself, you can be the best, most well-read doctor in the world. You can know your journals, you can know your textbooks. It's just not the same. The analogy I use is, it's the difference between a bird and a pilot, okay? A pilot understands lift and yaw and pitch and all these principles of how it's actually working. The bird doesn't have to think because the bird has a visceral understanding of how their wings work. It's the same with us. Like you and I got a completely separate and arguably more important education being patients ourselves than I would argue that we got in, the finest medical school or training program.
Absolutely. But I'm still kind of stuck on this whole like home MG tube thing. So but there's got to be suction associated with it.
Yes. So so we did. We're not so hardcore that we have in-wall suction at our home.
Like, what on earth did you attach it to?
Yes,
my friend.
We had a bag and we used gravity.
Did you have one of those baby things where what is that called? Do you remember those?
Oh, the thing that you suck the stuff out of?
Yeah, where you have to clear their nose and you stick a tube up there and then there's a filter.
Yeah.
A
we
bulb.
have a suction bulb as well. Yeah. It was
amazing.
very lovely, and I'm giving you a very skewed view of our marriage because honestly, it's usually lovely and wonderful. But it was such a...
I think, of course it's lovely and wonderful. Right. You're willing to put NG tubes in each other's
That's
noses.
Right.
I'm sure.
It says something about where you're starting from.
I don't know if you could do that for me.
I'd do it if I had to. As with most things, I will do it if I have to.
They're
I will
actually
not if I
kind
don't.
of hard to put in. I remember that.
What, Kristen, I think you've earned lifetime credit for successful out of hospital CPR without breaking any ribs. I think you're good.
On a bed.
I need to stop.
Forget.
I need to start giving you more credit.
That's right.
Absolutely.
I'm good in a pinch. If I'm not in a pinch and I don't have to do it, I'm not stupid. I'm not going to do it in that case.
So the other thing I wanted to follow up with, though, on this, which is an incredible story, is who exactly was tweeting for you? So it was people in the operating room,
Yes.
I assume, right?
Yes.
So did you enlist like a bunch of like students and residents and nurses and?
Well, I'll tell you, there's a little bit of backstory here too, which is that I had a surgery several years prior during my training. So I was doing my fellowship at the Mayo Clinic. That's where, as you do, I diagnosed myself with cancer. Yeah. And I was having my first surgery, which was on my neck. And the endocrine surgeon who does this part, and as much as I love my wife and trust her skills, even I wouldn't trust her to do this part of my my care. So this guy was cutting open my neck, and he said, "Listen," this came across almost like a pickup line. He's like, "Listen, your glands are huge," and I was like, well, "Thank you."
Got great glands.
And he said, "Got great glands." He said, "I'd like to make a training video." You can see where the seed is being planted here. He said, I'd like to make a training video for my fellows, because they won't often get to operate on someone that has the parathyroid glands that you do." So anyway, bottom line, Will, this was on VHS
like
tape.
top 1% of parathyroid glands.
Yeah,
just real.
Did you go out for dinner and a glass of wine afterward?
Yeah, he talked to me.
Awesome.
He's very charming. And this video that got produced was absolutely fascinating to me. And he gave me a copy like on VHS, and I watched it with like morbid curiosity. And it was so interesting. And I realized, if this is an educational resource for his fellows, fast forward to where social media is becoming a little bit more mainstream, I said, maybe there's a way we could do this when I go through my bigger surgery, which is on my pancreas, and it could be more of a public audience. So to answer your question, Will, this is where I have to give due credit to my employer. So my employer is Intermountain Health. They have a very forward-thinking social media department, clearly, because with about a week's notice, they and my surgeon, and this was the key part, came to an agreement. What my surgeon told me, and I'm actually curious to know if this is your mindset when you're in the OR. He said, "Listen, I don't care what is going on in the rest of the world. When I am operating, I am laser focused on the field." And he said, and I needed his permission clearly. He said, "I don't care if you bring in cameramen and people who are going to tweet. It doesn't affect my concentration." I was like, well, that's all I needed to hear. And so it was this whole team of professionals. And again, the fact that a major hospital system was willing to do this actually taught me a lot about the legitimization of docs using social media. Admittedly, not everyone uses it the way you and I do.
Right.
And I think it's important that you be authentic and have your own identity. But I found that quite legitimizing. That was 2017.
Wow,
that's incredible.
That's cool. And I totally agree. But with my surgeries, I only have to have laser focus for 7 minutes at a time. So we're talking a 6-7 hour surgery. But that's incredible.
Yeah.
Well, let's take a quick break and be right back with Dr. Mark Lewis. Hey, Kristen, I have a PSA for you and all of our listeners from our friends from Tarsus.
Let's hear it.
You know how sometimes you can get red, itchy, irritated eyelids?
Okay.
Well, do you know what that might be?
What?
Eyelid mites.
No.
Yeah, it's true. It's a disease. It's called Demodex Blepharitis.
That's disgusting.
It's pretty common.
That's horrifying.
So if you have itchy, red, irritated eyelids, go talk to your eye doctor. They can take a look at you.
Tell you if you're not alone.
That's right. But don't freak out. Just get checked out, all right? To find out more, go to eyelidcheck.com. Again, that's eyelidcheck.com to get more information about Demodex Blepharitis. All right, we are back with Dr. Mark Lewis. Mark, so there's a lot that I don't know about the world of oncology, and one thing I am aware of, and mainly it's through my research and the videos I've put together regarding the U.S. healthcare system and the exorbitant costs of everything. And one thing that always comes up whenever I'm trying to put together all this dialogue between Jimothy and United Healthcare is the cost of prescription medications, right? And it's probably no surprise to anybody listening, maybe it is, but oncology care has some of the highest, most expensive treatments, medications, chemotherapy that's out there. Is this a, before I get into kind of the little thing we're going to do here, is this a source of frustration for oncologists? I imagine it is, because you have to talk about these things with patients and the very expensive kind of cancer care that they often have to have.
Yeah, it's a frustration. Well, and more than that, it's a concern, because financial toxicity is such a real and even now under-captured outcome of what we do. Like, literally, when I'm sitting down with someone now, not only do I have to think about, okay, how do I help this person with their cancer? It's like, how do I make this affordable to sustain them? Because it's double jeopardy, right? Like, in this country, for the most part, people's healthcare coverage is tied to their jobs. Then you get these people who almost always, through no fault of their own, get diagnosed with a serious illness. And in my clinic, by definition, that's cancer. So now they're worried about keeping their insurance and juggling all the rigors of this diagnosis and its treatment. So you, more than anyone else, I think, have kind of cast in a sharp relief the true injustices and sort of unbelievable sort of leaps of logic that the system entails. And you basically got this collision between what I call the practice of medicine, which is what I do, and the business of healthcare, which is what you rightly satirize. So yes, long answer your question is, there are some medicines in oncology that are so ludicrously expensive that it actually gives you pause before you prescribe them. I'll tell you a true example. When I was in fellowship, there was actually an oncology drug that was so expensive. There was a single physician at the Mayo Clinic who was allowed to prescribe it. Like, unless you were this one doctor, nobody else could actually click. Yes. So to really kind of put a number on it, a single vial of this drug was $300,000.
Oh my gosh.
I actually remember thinking, it's good that they've got this system, because one errand click of my mouse, and I'm going to be doing my indentured servitude here the rest of my life. Like, I'm never going to be able to pay this off. So that's how ludicrous it's gotten.
So I want to talk about some of the costs of some of these. So I went on what I could find, GoodRx for some of them.
Yes.
Drugs.com. I don't know, just Googling around, press releases, because everybody loves talking about the price of some of these medications.
Yeah.
So I'm going to give you a medication, and I just want you to guess in US dollars, how much it costs. Okay. Some of these will, have been around for a while. Some of these are new.
Okay.
All right. We're going to start methotrexate for like a 30-day supply. How much do you think that is?
Gosh.
Wait, you have to tell me
like retail.
What kind are these all like?
These are all chemotherapy medications. A lot of them have multiple uses.
Okay.
It's not just cancer, but they are, there's different classes of chemotherapy drugs, but this would be one of them.
Okay. Can I just ask, is this Price is Right rules? Like, do I get penalized for going over, or?
No, just ballpark.
Okay.
Just ballpark.
I actually don't use methotrexate in my practice anymore, but if I had to guess, I would think a 30-day supply would probably cost you, and I would hope somewhere maybe around 1,000, low thousands is what I'm guessing.
It's actually much cheaper than that.
Oh, wow.
Methotrexate is quite cheap, about $100.
No.
$100
for everybody.
Right.
No, please
there
don't.
you go. I mean, it's a bit.
That is not medical advice.
But it's been around a while.
Yes,
it's been around a while.
Yeah, my legal team is telling me that I must strike that from the record.
Yeah.
All right. How about and some of I'm sorry, some of these probably you don't use frequently, but tamoxifen.
I used to use tamoxifen quite a bit. For a 30-day supply, I think probably in the hundreds of dollars, I would guess.
Yeah, about $100.
Okay.
So it's similar to methotrexate.
Is this pre or post insurance?
No, this is
just like
this
sticker
is
price.
Just like you don't have insurance. You're going to the pharmacy. And some of these you can get at the pharmacy. Some are not available. How about cyclophosphamide?
Oh.
So this is one. Do you I mean, that's like is that still used?
Oh yeah,
often?
It's absolutely still used. Yeah.
Okay.
Again, it's an oldie, but in the right setting, a bit of a goodie. I think we're probably still in the couple $100 range.
Yeah, $300, $400.
Okay.
All right. How about, here's one that I've been seeing a lot of commercials about. Keytruda.
Yes.
Keytruda. What is Keytruda? What is that used for?
Okay, so Keytruda by another name is pembrolizumab, and so that suffix. Anytime an oncologist sort of vomits syllables at you, the most important syllable is the last one. So the suffix tells you a lot. So that suffix MAB, that means monoclonal antibody. And to give it its fair due, Keytruda is one of these new immunotherapy drugs. And its most famous use or success until very recently has been Jimmy Carter. So President Carter, unfortunately, I think is now in hospice care. But that man has been alive for, I think, 6-7 years with a metastatic melanoma that went to his liver and his brain in his 90s. And so this drug, pembrolizumab or Keytruda, is an intravenous immunotherapy that actually teaches your body, hey, this cancer is not you. This is not self. This is something foreign that needs to be attacked like an infection. So long story short, very famous drug. There's no surprise you've seen it on television. But now we're rapidly escalating costs. And I think we're probably into the tens of thousands. I usually would tell someone that for a full course of Keytruda, and we can talk about how long that is. I mean, now we're into the hundreds of thousands. So, but a 30-day supply, I think would probably run you, I don't know, 30, 40, something like that.
Actually, in the tens of, so about 15,000 per month. Yeah.
The bargain basement. Let's go.
There you go. Not too bad, right? Yeah. All right. Here's another one. Garpazizumab.
Excuse me?
Yeah. Garpazizumab.
Garpazizumab. Okay. I'm actually not familiar with that one, Will. You're educating
That's because I made it up.
Yes. All right.
That's because I made it up. Yeah. That's
very tricky.
Changing the rules.
Yes. Yeah. Okay. And then at this point in my research, I was like, look, these numbers are getting very big. So let's just look at like the most expensive chemotherapeutic drugs out there. Can you guess the names of some of the more expensive, the most expensive ones out there?
Well, the one I was mentioning earlier, albeit not by name, was the one at Mayo that required essentially this unbelievable complicated system of ordering. So it was eculizumab, is a monoclonal antibody used in paroxysmal and nocturnal hemoglobinuria, all of which just rolls off the tongue. And that was $300K per vial. So I'm guessing whatever drug you've come up with probably ends in that MAB again. Because those are there may be an IB in there too, but
the MABs and IBs.
The MABs and IBs, yeah. If you again for your
most
videos,
of them are also these brand names, right? Because that's what they're marketing them as. And I have to say the most expensive one out there is an ophthalmology medication.
Oh,
so it's called Kimtrack. Have you ever heard of Kimtrack?
No, do tell.
It's for uveal melanoma.
Oh yes. Do you have its generic name by any chance?
You know what? I do not.
Okay, I think one of my colleagues.
I'm a bad doctor. I don't have the generic names.
No. You're the last person that anyone would accuse of being in the pocket of pharma. Well, don't get me wrong. One of my colleagues who treats uveal melanoma, I think uses that drug, but they use a different designation for it. I've heard it's quite. I mean, that
$81,000 per month. $81,000 per month.
So I think your larger point is, we have to be incredibly selective in who gets these drugs. And we cannot be putting the entirety or even the majority of the bill on the patient. And maybe and I realize this is taking your game and putting a very serious spin on it. The other thing
that's the point.
Okay,
that's the point. It's less of a game and more just a way to complain about things.
No, this is great. You've it's the Trojan horse of your comedy. You've gotten the message in there. It's not sustainable. It's not sustainable on a system level. It is absolutely not sustainable on a patient level, because short of people that are truly independently wealthy, who can afford any of this?
How's anyone supposed to do that?
Yeah.
Right. It's not possible.
Is that how much they cost to make, or is there some ridiculous markup happening?
Well,
I'm afraid I already know the answer to that.
They certainly want to like recoup their costs of making it. I think part of the problem was also how rare the disease is, right? Because some of these are like orphan drugs.
Yes. As a general rule, the rarer the disease. And here's the thing, right? We do walk a very tricky tightrope here. We don't want our pharmaceutical colleagues, who are not, by the way, are not universally bad or avaricious. We literally can't do our work without them. I have to say that quite authentically. But we have to be so thoughtful about who we give this to. And to your point, Kristen, price point. So the company line, literally the company line that you usually hear is, if we didn't charge this much, we wouldn't be able to reinvest in research and development. Okay. But then when you actually look at where the money goes, I mean, these are for-profit companies for the most part. They have shareholders who they are beholden to. And those people are, expecting, quarterly profits, right? So I hate to be so cynical in my answer, but I'm going to tell you my honest feeling about this is that I do think there's considerable markup. And I think it's what is the system willing to pay? And our day of reckoning is coming if it isn't already here. Medical bankruptcy, and this is horrible to say, is the number one reason that Americans go into bankruptcy right now. It's not home foreclosure. It's not anything else. It's bills. And Will, I know you had your own nightmare after your cardiac arrest. My dad, back in the late 80s, early 90s, fought I think a $30,000 bill. And it pained me to watch him. Obviously, I was very young at the time, but I was aware it was certainly money we didn't have. It was also energy this man didn't have. Like, he didn't need to be using his time on this. And he was so nice and like endlessly patient with these people. And I think there was a part of him that, at base wanted to believe they weren't driven by greed, but they still wanted their money. And because he hadn't, quote, played by the rules and some prior auth hadn't gone through properly, like, the patient ends up on the hook. And I hate a system that does that, puts the onus of responsibility on the wrong patient. And the last thing I'll say, Will, before we move on, is a lot of cancer drugs these days are pills. And that's particularly a problem because while it sounds more convenient, you'll appreciate that a lot of prescription plans don't cover pills. I was literally on the phone with an insurer last week, and they were like, hey, Dr. Lewis, you prescribed XYZ. This patient doesn't have pill coverage, but they do have IV coverage. And I said, well, that would be great, except the medicine I want to prescribe literally doesn't have an IV formulation. It's only oral, and the patients didn't have coverage for it. So we're having to, go and beg the drug company essentially to give it to us for free.
Yeah.
Who cares what form it comes in? Just pay for the drug. Like,
so
that's so dumb.
So, and some of these, I'll just, some of these chemotherapy drugs, the numbers are, 70,000 per month, 60,000, 20, 30,000. And what I kept thinking about is just from the perspective of a cancer patient, because, we really tout our science and development and R&D that we have in this country that allows us to have these incredible therapeutics that can take we have gene therapy now that, and we have in ophthalmology and other areas. And so the fact that we have the ability to treat these fatal diseases, but unfortunately, the financial cost is so great that makes them sometimes unavailable for people. It's really and
they're taking advantage of people in such a vulnerable position, because for many people, you'll do anything, right? Anything you can do at all to keep living. So
the fact that that my patients starting GoFundMes for their treatment. That's not the exception. That's nearly the rule, and it breaks my heart every time. And then, Kristen, to your observation, one of the things that hits me like a fist every time I hear it is sometimes I'll present to my patients their treatment options, and they will forego one of these treatments that Will has listed off, not because they have doubts about its effectiveness, but because they don't want to deplete their nest egg. They want to leave something in their inheritance for their family. And that is just like,
that's heartbreaking.
It's absolutely heartbreaking, right?
To have to make that choice.
Right. Yeah. And usually what will happen is the relatives will pipe up and say, oh, don't worry about that. We'll be okay. But then I feel, this is maybe the kernel of your question, Will, I feel like I have to be thinking about that too. And, there's the science part, but there's also the, sort of implementation part. And the two have to find some sort of harmonious coexistence.
All right, let's take one more break, and we'll come right back with Mark Lewis. Okay, we are back and ready to look at some of our favorite medical stories that were sent in by the listeners. And we still have Dr. Mark Lewis here with us to react to these stories as well. So we have Trish. Trish says, I am a radiographer in Sydney, Australia, and I'm also the educator for our department. I really enjoy my job, and one of the best parts is showing students the ropes. A few years back, I had a first-year radiology student on her first placement with me, and she was super keen to get stuck in round on resuscitation. So this is a I'm
She
guessing
wanted to
that's
see some of that.
Yeah, she wanted to see
action
some of that.
happening. Okay.
So we get a page for a trauma call and grab the x-ray machine and head over there. Just as we walk into resus, this area, the first thing we're greeted with is the ED team performing a lateral canthotomy on a severely injured patient.
What's a canthotomy?
So it's where there's facial trauma and you have to cut the eyelid
Nope, don't
to
want to know.
release pressure to prevent
Stop.
blindness. That's what it is. My student whispers, "Can I go to the loo?" and shuffles off. When I caught up with her about a half hour later, she apologized and sheepishly said, "Is it always like that?" And I reassured her that no, thankfully, that's not a common sight. She was fantastic after that initial moment of terror. She didn't pass out though.
Well, yeah,
because that's a common thing that happens for people. In fact, that's how a lot of students realize they don't want to go in certain areas of medicine.
Right, whatever makes you go vasovagal.
You get the vasovagal. But I will say a lateral canthotomy is a challenging procedure to watch if you've never seen something like that, because people already have weird eyeball stuff. Have you ever seen a lateral canthotomy done?
Yeah, Mark? And I'm grimacing because better you than me, my friend. Like I listen, I love what you do. I know I couldn't do it, and my first reaction was absolutely Kristen's. That give me the patient who's got septic shock in the ICU any day. I can manage them, but give me a lateral canthotomy and I'm going to call it Dr.
And there's a lot of, it's very vascular, the face and the eye. So you get a lot of bleeding when you do that. Okay. So we have Jed. This is our second story. There was a guy I knew in the Navy. You know, this is going to be a good story.
Yeah. Just from that beginning, buckle up.
He had testicular cancer and had a prosthesis. The Navy is an interesting culture to work in. That's what he says. And this was on a submarine, which is a unique environment even by Navy standards, and was all male at the time. The uniform at sea is just coveralls, which zip from the groin on up. This guy was known to occasionally unzip his coveralls, put his testicles on top of, if I remember correctly, the giant steel case of the main engines, which had a bit of a wide ledge around waist height, and take a hammer to his fake testicle for the purpose of freaking everyone out.
That's not where I thought that was going. I thought he was going to zip him up, but he took it to a whole different level.
This is a little Navy prank. Crushing your fake testicle with a hammer, you know. Not a bad prank, to be honest.
Yeah.
He
says it worked.
If you're gonna have if you're gonna have any kind of cancer, you know, having fun with it, I think, is always something that we should support.
It's a silver lining.
I'm feeling so shortchanged. I only have half a pancreas. I can't pull any pranks. Like I have no physical jokes.
That's
sour grapes. Sour grapes, man.
Brainstorm something for you. Okay, maybe that'll be the game next time. Is come up with cancer pranks.
Yes.
All right. Well, thank you for those stories. You can send us yours, knockknockhi@human-content.com. Mark, thank you so much for joining us. It's always a pleasure to talk with you. And do you have something you want to promote? In fact, I would love to promote this as well. March is Colon Cancer Awareness Month, right? So we're recording this now. It's in March. This will go out in May, but I want you to just let everyone know, what should they know? What should the general public know about colon cancer?
Oh, you're very kind. Let me do this. And thank you for sharing your platform. So we know that colon cancer is shifting earlier in age of onset. And again, this is something no one really likes to think about or talk about, but just in the last couple of years, the guideline for when people should start screening the colon is not 50 anymore, it's 45. So my message is, if you are 45 years old, it is very reasonable to talk to your doctor about what's the best way of doing this. And there's really two approaches, one of which is colonoscopy, which everyone is familiar with the fact that requires prep. You have to clean the colon before you can see the colon. That said, once the prep has happened, the easy part actually, relatively speaking, is a doctor using a camera, a flexible camera, to look at your colon. And it's 2 for 1. I like to say it's not just screening, it's prevention, because if the doctor finds a polyp, they remove the polyp. And there's very few tests in medicine that are quite so efficient in identifying and then getting rid of your issue. The other way you can do it, and I know this is lovely to talk about, but I have a feeling this is the right podcast to do it, is to test your stool. So these days we have some pretty sophisticated home tests. So, Will, you'll remember that one of the more glamorous parts of medical training is you and I probably had to do plenty of digital rectal exams. We had to put fingers in people's rectums. Turns out that's actually somewhat traumatic in every sense of the word. And what I mean by that actually is it has the potential to introduce even microscopic amounts of blood, just that digital trauma.
Gotcha.
So we don't actually encourage testing that way as a routine anymore. The better way of doing it, and it sounds so weird at first, is to provide the patient with a home kit, which they complete in the privacy of their own bathroom and they mail off. Now, here's the key. If that kit comes back showing blood or showing, we're actually sophisticated enough now, we can sometimes find precancerous DNA in stool. That then essentially requires a follow-up colonoscopy. It's an incomplete screen. If we see there's something wrong in the stool, we're not just going to say, okay, come back in 10 years. In fact, stool testing is annual. But the positive stool test has to be followed up with a colonoscopy. So thank you so much for letting me talk about this. And I will say that maybe the last word is this is all about screening. It's a completely different story if you have symptoms. And again, no one wants to talk about this.
Right.
But if you're having blood in your stool, it's very easy to be like, oh, that must be hemorrhoids. It's nothing to worry about. But unfortunately, it's not always quite that straightforward. So it's definitely worth bringing to the attention of your doctor. For all the jokes that we make, we will treat your encounter with complete confidentiality and make sure that you're well taken care of. And so this is an important time to talk about colon cancer awareness. Is no longer for people 50 and up. It's actually for 45.
Yeah. Okay. That's not too far off.
I know. I'm getting uncomfortably close.
You know what? I'm going to get my colonoscopy and you're going to live tweet it.
Okay, deal.
That's what.
I literally have the same deal with my wife. That's fantastic.
Yeah. Because I'm getting that sweet propofol. I'm going to be out and you're going to be watching my colon on a tiny little
I'm going to be
screen.
telling everybody about it.
Yep, that's right. Well, Mark, again, thanks so much for being with us. And it's always a pleasure.
Good to talk to you.
Listen, you guys, I know it seems like I'm paying you lip service because I'm on your podcast. Thank you legitimately for what you do for humanizing doctors, because, I shared that Google search earlier. It's actually terrifying to me that there are people out there with a serious illness like cancer who are almost as afraid of the physician as they are of the disease. And I realize that you have a tremendous amount of, talent that goes into your craft. But I want you to know that one of the real world impacts, I really mean this, is you are helping to not undermine our image, but soften our image. And that means the world to me as a medical professional. So from me to you, thank you. Appreciate it. Kristen, for you, I saw my wife and frankly, my mother, sometimes with the best intentioned doctors almost get sidelined. Like, focus understandably at the time was on me or my father, but that can't happen at the expense of completely forgetting about the caregiver. And I'm not saying anyone out there listening to this has to be, performing medical procedures on their loved one at home. My wife is an exception, as are you, with Will. But no, thank you for what you've done, because, I've tweeted about this. I'll say it now on your platform. COVID was a case of not realizing what you've got till it's gone. And during the really scary times of near quarantine, where my patients, when they were in the hospital, they were not allowed to have visitors.
Yeah.
I realized not only are they isolated, I can't do my job as well. Like the patient's friends and family are their therapeutic allies. And yes, you may not have a formal place in the medical record the way that the patient does, but we cannot forget about you guys. And in fact, we owe you a tremendous debt of gratitude. So again, from the bottom of my heart, thank you for what you've done. I am a huge believer, as you know, of the co-survivor sort of movement and the attention you brought to that.
Thank you.
And again, I know this is kind of turning into a love fest, but it's one that comes from the most genuine of places. So thank you guys both very much.
Thank you. Appreciate
that.
Thank you. And people can find you on Twitter. And what's your handle?
Oh, it's extremely creative. It's at Mark Lewis, MD.
There you go. Easy to remember.
Yeah,
that's good.
Exactly. And thank you.
And you also are working on a memoir.
Oh man, I am actually both terrified and actually really glad that you asked me this, because
now you have to do it.
No, it's public.
Well, yeah. So everyone that walks into my office, I'll even turn my camera for a second. I've got this like beautiful mind situation going on where I've been scrawling notes on this whiteboard for like a couple years, and people literally think I'm having some sort of nervous breakdown. They're like, "Are you okay?" And I'm trying to turn this mess, which is in my own illegible handwriting, by the way, trying to turn this into a book. And I'm so inspired by people that have written medical memoirs. I'm inspired by my dad. He wrote one when he was dealing with cancer. And so I better get pen to paper and finish mine. So thank you for seeing.
And what's his called?
So his is actually a theology book called Between Cross and Resurrection. To his enormous credit, he spends about 10 pages out of 450 something talking about himself because he didn't want to be the center of attention. But the fact that he wrote it on a typewriter late at night after chemo sessions was like, that to me is my fuel.
Yeah.
And so thank you for saying that. And now, Will, I got to finish the book. So thank you.
There you go.
Yeah.
All right.
Yeah.
Well, thanks again, Mark.
Thanks,
Bye.
guys. Appreciate it.
Well, that's our episode for today.
Yes. Dr. Lewis, he is such a good human being and does a lot of really good things in his practice.
We didn't mention this, but my mom has been going through cancer treatment, and I've talked about this on social media a little bit, and she's now friends with Mark.
Yes.
And they've been talking with each other. He's just a fantastic person, and
really is.
helped out our family quite a bit. So definitely check him out on social media.
Well, and we were just telling our producer that your mom and his mom are now pen pals too.
They are.
Through all of this, which
are.
is really adorable. Your mom lives in Houston and his mom lives in Scotland, so it's a long distance relationship.
And my mom's got a very quite thick Texan accent.
Yes. So must be interesting.
Between the Texan accent and the Scottish,
right.
It's probably a fun
probably
conversation
no one
to listen to.
them.
At least maybe for a future episode, we just get the two of them to talk to each other for a while.
bonus episode. That would be hilarious.
Well, thank you all also for the stories, for your own stories, and let us know what you thought of the episode. And what areas of medicine do you like to hear about? Because, I want to try to hit up every part of medicine and have different doctors from different specialties. And so let us know what you're looking for, what you like hearing, or what we haven't touched on that you want to hear more of. Yeah. There's lots of ways to hit us up. Email us, knockknockhi@human-content.com. We're on social media, pretty much everything, Instagram, TikTok, Twitter, YouTube. You can also hang out with our Human Content Podcast family on Instagram and TikTok at Human Content Pods. Shout out to all the great listeners leaving awesome feedback for us, all the reviews. We love it. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. Like Spriggan on YouTube said, it's so cool that Lady Glaucomfleckens' grandpa invented the baby vacuum.
The baby vacuum.
The disposable. We don't want to give credit to the...
I think there's probably a more technical term for it. It's the vacuum extractor.
The vacuum,
that's what it's called.
A type of vacuum extractor.
Yes.
But yes, baby vacuum works. Yeah.
Yeah. Right. He invented a specific... We don't have to get into that. But yes, it is so cool.
And Spriggan says, I had a vacuum-assisted delivery just 1 month ago, and while my baby still has a knot on his head, I am grateful that we were able to avoid a forceps or cesarean delivery. Thanks, Grandpa.
Yeah, thanks, Grandpa.
Full episodes of this podcast are up on YouTube, my YouTube channel at @Glaucomflecken. We also have a Patreon, lots of cool perks, bonus episodes, or react to things, medical shows, movies, hang out with other members of this community. We're active there, posting videos and comments and all the things. And we have early ad-free episode access for you, interactive Q&A live stream events, a lot more. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, new member shout out to Leah D. Thank you, Leah. Welcome. Also, shout out to the Jonathans, as always. Patrick, Lucia C., Sharon S., Omar, Edward K., Stephen G., Roskbox, Jonathan F., Marion W., Mr. Granddaddy, Caitlin C., Brianna L., Dr. J., Chaver W., Jonathan A., and Leah D. Patreon roulette time. This is where we give a shout out to somebody in the emergency medicine tier of Patreon. So our drum roll, please.
I can't do it.
Just try it. I want to hear you try it.
I got dental work done recently.
Shout out to Chris M for being a patron. And shout out to Kristen's dentist. We are your host, Will and Kristen Flannery, aka the Glaucomfleckens. Special thanks to our guest today, Dr. Mark Lewis. Our executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineer is Jason Portizo, and our music is by Omar Binsfi. To learn about our Knock Knock Highs, program disclaimer and ethics policy, submission verification, licensing terms, and HIPAA release terms, you can go to glaucomfleckens.com or reach out to us at knockknockhigh@human-content.com with any questions, concerns, fears, hopes, dreams, or medical puns. Knock Knock High is a human content production.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.